Hello, I'm Ben Pryor, and I'm an advanced first contact mental health practitioner. I'm part of a team that works very closely alongside the GPs, other nurses, members of the nursing team, and other allied health professionals in GP surgeries mainly. Myself and Dr. Ruth Walker, is one of the GPs at the Primary Care Network, decided to create a multidisciplinary team. So the needs that would come in to a multidisciplinary team meeting can include physical, mental, biopsychosocial needs, realistically. We look at considering all of the needs of the individual in order for us to tailor and formulate a plan towards what's the best pathway and direction to help the individual. So it helps the GPs in a number of different ways. It helps the GPs in understanding and having access to systems that we use in mental health trusts, which they don't have access to readily. It helps by offering a timely meeting on a twice-monthly basis where there's a space which is a confidential and open space to have a discussion. We try and work alongside and with the GPs in understanding their busy time schedules. We'll actually offer a specific diary slot if they are able to come. The benefit of having a GP present at the MDT rather than speaking on behalf of the GP is that we can ensure that all information that's pertinent and relevant to the individual is not lost in translation through another professional. So the information can be first-hand, and if there's any questions that need to be asked as part of that MDT from any other professional member who's at that meeting, then they can ask that directly and gain the response in a timely and efficient fashion.
Hi there, my name's Kate McCormick. I'm the team manager of the South Community Mental Health team. Having the key players in one place allows GPs to come and present a case and make sure it goes to the right service at the right time, rather than finding frustration at sending somebody to one service and identifying they didn't have a piece of information or that it was the completely wrong service, and signposting people left, right and centre. Somebody being placed on the wrong waiting list can obviously be really detrimental if there's a 3-4 month wait. Having those conversations up at the beginning ensures that we get the right clients to the right place at the right time. Having the variety of professionals in that MDT also enables professionals to have a profession to profession discussion when it's most needed and most appropriate. So, for example, if a psychiatrist comes and there's a GP with a medication query, they can have that two-way dialogue and discuss and identify what treatment is most effective, rather than sending various letters and emails. Having professionals in the MDT who deliver some of those interventions also enables GPs to get a better understanding of maybe what they're asking for or what the client is asking for, and appreciating what work may have been done or why decisions were made. For example, as a CMHT, we were trying to discharge an individual who we didn't appreciate how much challenge that was bringing to the GP. So by understanding that from the GP's perspective, we were able to do a much more graded ending of care, which was more beneficial for the client, but also both services involved. When there is a client who's needing a significant amount of input, having a GP MDT with lots of services involved means the GP can ensure multiple needs are being met at one time, rather than waiting for one person to refer to another. Actually, you can set off that coordinated response from the start, rather than waiting for services to refer to other services later down the line.
Hi, I'm Alan Bednar. I'm a clinical lead with York and Selby NHS Talking Therapies. Another challenge that GPs face is that many different services we're all on different electronic platforms, or the files are in different databases, which can really limit the perspective that GPs will have as to who their clients are open to, their current, are they on a waiting list, are they in treatment? Whereas the MDT gives an opportunity to hear, to see from all different angles where your client is, who they're with, and the engagement that they've had, and to get that update in real time. Some of the MDTs that I've had a chance to be a part of, which I think have probably had the most benefit, have been times where the mix of people around the table has led to a conversation that wouldn't have happened if we'd all been individuals thinking about the client. One person can say, from their perspective, have a suggestion, which is picked up on by somebody else. And by the end of the conversation, we've reached a conclusion or an option forward that none of us would have had without that dynamic. And that's a benefit you can only get from the MDT. So I think there are loads of opportunities for GPs with respect to the MDT. It's an absolute challenge for them to find the time. However, it pays back in so many different ways. A conversation of 3 minutes is going to save you 10 letters. What other opportunity is there to get everyone from a psychiatrist to the council to all of the mental health teams in between talking together about your patient? That can make a real difference.